Thank you for joining us for this targeted oncology virtual tumor board, which is focused on skin cancers. Today, my colleagues and I will review 4 clinical cases on both melanoma and non-melanoma skin cancers. We will discuss an individualized approach to treatment for each patient, and we'll review key trial data that impacts our decisions. I am Dr. Ahmad Tarhini, Senior Member and Director of Cutaneous Clinical and Translational Research at Moffitt Comprehensive Cancer Center and Research Institute in Tampa, Florida. Today I am joined by Dr. Meredith McCain, an investigator in the Melanoma and Skin Cancer Research Program of the Sarah Cannon Research Institute in Nashville, Tennessee. Dr. Deborah Wong, Assistant Professor of Medicine in the Division of Hematology Oncology at UCLA Medical Center in Los Angeles, California. And Dr. Kevin Emrick, Co-Director of the Multidisciplinary Cutaneous Oncology Center, Assistant Professor of Otolaryngology, Head and Neck Surgery at Massachusetts Eye and Ear at Harvard Medical School in Boston, Massachusetts.
So our first case is an otherwise healthy 69-year-old male. He's fair-skinned and a retired construction worker. He recently presented to his primary care physician with what he described as a wound behind his ear that wouldn't heal. He's noticed this for at least 4 months and also began to notice some numbness in the area. He was referred to a dermatologist that specialized in skin cancers. He's generally a healthy gentleman with an ECOG performance status of 1. On exam, he has a 4.5 centimeter ulcerated lesion in the postauricular region that felt greater than 5 millimeters thick. He had no palpable lymphadenopathy. The dermatologist performed a biopsy which revealed poorly differentiated squamous cell carcinoma, 7 millimeters thick and into the subcutaneous fat.
Thanks, Kevin. Interesting case. So we'd like to start the discussion. What are some of the high-risk features of this patient's cutaneous squamous cell carcinoma?
So I think one of the obvious ones, this is a large lesion. It's 4.5 centimeters. We usually use that 2 centimeters as an initial cutoff and 4 centimeters as another cutoff. Thickness, I think, in this case is also important. And there's 2 features to thickness. One being greater than 6 millimeters. In this case, it's at least 7 millimeters. And into the subcutaneous fat, I think, is an important depth feature as well.
I think also the poorly differentiated nature histologically also probably contributes to being a higher risk.
We also don't know from this path report whether or not there's perineural spread, perineural invasion, lymphovascular invasion, which would also make this additional high-risk features.
Mm-hmm. The NCCN guidelines present a nice definition of high-risk and low-risk features. If you could discuss this, Kevin.
So the NCCN guidelines break it down into 2 different categories. One being a little bit more clinical, so size greater than 2 centimeters. There's some nuance to that lesions in the M or the H distribution, if it's greater than 1 centimeter, they consider to be high risk. When you look at the lesion, if the borders are a little bit irregular, is considered high risk. Tumors that come back, that are recurrent in nature, are high risk. Our immunosuppressed population, that could be solid organ transplant, CLL patients, patients who are on biologics for rheumatoid arthritis, for example, can contribute to immunosuppression. One of these that occurs within a site of previous inflammation or radiation can elevate the risk. And tumors that grow quickly or have some neurological symptoms are also high-risk features. The second part of the NCCN guidelines are the pathological features, a few of which we've mentioned: poorly differentiated, greater than 6 millimeters or into the subcutaneous fat, as well as the perineural and lymphovascular involvement that we mentioned. And the last one is some of the subtypes that we sometimes see on the pathology reports with acantholytic, adenosquamous, different types of metaplastic subtypes that are sometimes described are also considered to be high risk.
Very interesting. So what additional testing would you order in the treatment planning of this patient?
For me, this is in a location that The exact depth of it, and is it invading into some of the nearby mastoid bone in the postauricular region? Is it coming, sneaking down into the ear? Are really important things that can be hard to tell on exam. And so I think a CAT scan with contrast of the head and neck region would be an important next piece of information in the workup.